All right, so you're already pretty handy with a thoracic ultrasound probe. You know your way around A lines, B lines, and lung sliding. But what's next? Well, the next huge leap in your diagnostic power isn't about getting a new machine. It's about expanding your view. In this explainer, we're going to show you how to use those very same skills to look beyond the chest and get critical answers right at the bedside in seconds.
This quote right here, it really nails what we're talking about today. This isn't about going back to square one. It's about leveraging the skill you already have. We're talking about taking something you're good at and making it exponentially more powerful. So here's our game plan. We'll start close to home with signs that directly connect to the cardiopulmonary system. Then we're going to zoom out and look at the bigger systemic picture. Think abdomen and vasculature. And finally, we'll tie it all together to see how this truly changes things right at the bedside. Okay, let's dive right in with the cardiopulmonary connection. These first three signs are probably the most natural next step from thoracic POCUS because they give you this immediate, incredible insight into what the heart and hemodynamics are doing. First up, the intracardiac thrombus. Now, look, a full-on echo is obviously the gold standard, right? But in an emergency, when you're worried about a massive PE, being able to spot a big mobile clot yourself can be an absolute game changer.
And the practical side of this is key. You're using views you might already know, the apical and subcostal. You're just aiming that probe to look inside the right ventricle and right atrium for these bright mobile masses. The trick is to confirm it in more than one view, so you know it's not just an artifact. And the clinical value? It's huge. Finding a clot in transit can completely change your decisions on anticoagulation or thrombolysis right then and there.
Okay, moving on to our second sign, the pericardial effusion. This one is such a classic mimic. You could have a patient who looks for all the world like they're in heart failure or having a PE, but the real culprit is purely mechanical. It's fluid squeezing the heart from the outside. So the really important part here isn't just seeing that black anechoic fluid around the heart. The critical question is it causing a problem? Is it causing tamponade? So you're hunting for these red flags, like the right atrial wall buckling in during systole, or the right ventricle collapsing in early diastole. These are the signs that tell you the pressure in that sac is so high, it's actually stopping the heart from filling properly. And this is just a beautiful example of why POCUS is so powerful. In literally seconds, you can go from a huge differential diagnosis for shock and shortness of breath to one very specific, life-threatening, and most importantly, fixable problem. This is how you save lives with this tool. All right, let's move to one of my personal favorites, one of the most useful ancillary signs out there, looking at the IVC. Think of this as your personal window into the body's plumbing, specifically right-sided pressures and volume status. It helps you sort out what's really going on. Is it hypovolemia, RV failure, or something like tamponade? The technique itself is pretty straightforward. You'll get your subcostal long view, find where that IVC pops into the right atrium, and then measure the diameter just a couple centimeters below where the hepatic veins come in. And the last crucial step is the dynamic part, the sniff test, to see how much it collapses. And for your spontaneously breathing patients, these are the numbers you gotta remember. If you see a big, fat IVC, we're talking bigger than 2.1 centimeters, that collapses less than 50% when they sniff, well, that's a very strong clue that their right atrial pressure is high. It's a massive piece of the hemodynamic puzzle. Okay, let's widen our lens a bit. We've been focused on the heart and the great vessels. Now we're moving on to scan the systemic picture. These next three signs, hiding out in the abdomen and the vasculature, can give you some amazing context for your patient's respiratory problems. Now, this one might feel like a bit of a leap. A liver scan? But a quick look at the liver can be incredibly high yield, especially if you've got a patient with, say, an unexplained pleural effusion or you're worried about malignancy. And the best part? You're already right there when you're looking at the IVC. So what are you looking for? Well, they can look different. Sometimes they're hypoechoic, which means they look like dark spots compared to the rest of the liver. Other times they're hyperechoic, so they'll show up as bright spots. The key is just to fan through the whole liver and keep an eye out for any of these odd-looking lesions. The real usefulness here is all about triage. Finding what looks like liver mets in a patient with a new effusion can just slash the time it takes to get to a diagnosis. It's not a replacement for formal imaging, of course, but it helps you prioritize what to do next, and fast. And while you're scanning that same area, another super simple but really powerful sign is ascites. For a patient who's short of breath, finding a belly full of free fluid can immediately explain why their diaphragm is pushed up on the chest x-ray and why they're working so hard to breathe. The main spots to check are the dependent areas, like Morrison's pouch on the right and the splenorenal recess on the left. You're looking for that black, anechoic fluid outlining the organs, and this is where you can really start connecting the dots. Let's say you find ascites and you already saw that big non-collapsible IVC. Well, now you're building a really strong case for something systemic, like right heart failure or massive volume overload.
All right, for our sixth and final sign, we're heading down to the lower limbs for a quick DVT screen. If you have a patient with unexplained hypoxia and you're thinking PE, this focused little exam can skyrocket your diagnostic certainty, right there at the bedside.
Now, just to be clear, this is not a full vascular study. Think of it as a rapid, high-yield screen. You're just focusing on 3 key spots where clots love to hang out: the common femoral vein right at the groin, the proximal femoral vein just a bit below that, and the popliteal vein right behind the knee.
And the principle here is so simple, it's beautiful. A healthy vein is like a straw. It squishes flat with just a little bit of pressure. But a vein with a clot inside, it won't collapse. That failure of the vein walls to touch, that's your positive finding. It's as simple as that.
And the clinical payoff is just undeniable. You find a DVT in your patient with respiratory symptoms, your suspicion for a PE goes through the roof. It lets you risk stratify and escalate their care immediately, often before you even get that formal CT scan back.
So let's pull all of this together. We've covered 6 really powerful signs, from the chest to the abdomen to the legs. But the real question is, what does this all mean when you put it together in your day-to-day practice?
Okay, here's the bottom line. You are building on a foundation you already have. By just adding these quick looks, you massively broaden your diagnostic capability, letting you make critical decisions when every second counts. But, and this is super important, remember that these are screening tools. They're meant to complement, not replace, formal, comprehensive imaging.
You know, the real power of this isn't just knowing the information, it's actually using it. So as we wrap up, I want you to think about your own patients, your own practice. Which one of these 6 signs are you going to try out first? Which one is going to make the biggest impact for you starting tomorrow?